I welcome everyone to our panel discussion. My name is Dr. Nyawira Mwangi, and I am privileged to be moderating this discussion. I'm happy to be discussing with Dr. Helen Roberts, Dr. Frederick Correll, and Dr. Michael Gishangi. We'll be discussing about the conference and post-Vision 2020 agenda. So let me begin with Dr. Gishangi. How valuable is this conference to you? What's your take-home point so far? Dr. Gishangi. Meantime, as he prepares, Dr. Correll, how valuable is the conference so far?
The conference is great. So far, I'm really learning a lot. I enjoyed Professor Karimoria's session, very inspirational, and you know, some of us are still young in our career, and seeing how he's maneuvered his way is quite admirable. Thank you.
How is it? How is it to you, Dr. Roberts?
Yes, I think it's great. I mean, it's so amazing, isn't it, to be able to sit at home and learn this and invite in people from all over the world. I think we've got speakers tomorrow from Britain. They haven't had to leave their home either, so it opens it up massively. It's very exciting. So yes, I'm enjoying it very much so far. And thank you all for your patience with the technology involved. We all have to learn it. It's an essential part of moving forward. Very exciting.
Thank you very much. Dr. Gishangi, we're having this conference amidst the COVID-19 pandemic. What are some good things about holding a conference in the new normal of the COVID-19?
Thank you very much. One thing I want to say is that despite the fact that we could not meet physically, we've been able to interact as eye care workers and deliberate on issues related to eye health and moving forward. And from this, we also learned that it is possible to go beyond being locally placed. For example, in the capital city, you're able to link up with people working in far ends of Kenya, like Turkana, Mombasa, Eldoret, and so forth. And so it is possible to harmonize eye care and improve quality, you know, in a more generalized way. This is one of the key lessons we are bringing on board at this time of COVID. The other thing is that, as I had mentioned earlier, simple primary healthcare interventions are useful in disease prevention, not excluding eye health issues.
Okay, thank you very much for that input. One interesting thing in this conference is we have had the patient voice in at least 2 presentations. What did you find out from the few minutes that we had the patients speaking? Maybe I can begin with Dr. Roberts.
Well, I thought it was really shocking, her plea for empathy, didn't you? That was really struck me to the heart. You know, there we are trying to get the job done and trying to get the clinic finished and trying to get the patient treated and out of the door. And very few of us ever really understand how it must feel to have irreversible blindness and face life with that, and face coming into our clinics and being treated as we treat people, which is, you know, let's get them done and out of here as quickly as possible. I think that really hit home.
Absolutely, yes. She talked about, you know, we are people with feelings, with aspirations. I found it also quite astonishing. Dr. Correll, what did you think?
The same thing as Helen Roberts has said. And the other thing that just came out in both patients is the fact that, you know, they lack information. You know, we don't have adequate information to teach them more about their disease, or something to make them even aware that there were such things even before. So those were some of the things that came out: lack of awareness, and I guess in this time of this era of information, there's a lot of misinformation as well, as one of the patients also highlighted, they get information from friends, the internet, who knows what they're looking at. Thank you.
Thank you very much. Dr. Kishangi, we had one of the patients portraying the scene in a rural area and another one in a maybe urban area. What is what's a typical patient that we get in our services, and how should we relate with them, Dr. Kishangi?
First, I want to add the fact that there is significant lack of awareness with people not knowing, exactly what is happening to their eyes. And I was really touched by the patient who had irreversible, or rather glaucoma. And most of the people we get in the field, they don't have the information and they don't know what to do. Some situations like glaucoma, even the treatment does not give immediate relief outcome. Now, I was also impressed by the fact that patients are taking up the initiatives to develop some support group, which is out to mean that they are taking responsibility of their health, which is probably a key issue that we need to support. Because the moment they take responsibility of their health, then the demand for services will be high. And I think that is something that we need.
Thank you very much. That World Report on Vision, which Dr. Kishangi also touched about, it has 5 recommendations, but one of them is about patient-centered care. So in the Post-Vision 2020 agenda, the World Report on Vision is guiding us to conceptualize what we should do next, and patient-centeredness has been identified as a key priority. Maybe Dr. Koril, how can we demonstrate patient-centeredness in a conference like this?
I think already, Dr. Nyawira and the entire scientific committee have done that. They've demonstrated being patient-centered, and we can meet in a conference and discuss big ways of treating glaucoma, and the patient is really concerned about some of the little things. How can I get around my house as I deal with this disease? And maybe we need to, in a conference like this, we need to highlight that. Maybe we need more patient voices coming out a little bit more in conferences, as opposed to these high technologies at times. So I think it's a call to be sensitive towards some of the really important things and things that matter to the patient. And we need to bring that out in a conference. Thank you. And I think we kind of are on the way there. Thank you very much.
Okay, excellent. How about in clinical services? Let's say in outreach programs or in outpatient facilities, in surgical facilities. How can we be more patient-centered? Do you have some thoughts on that, Dr. Roberts?
Yes, I think it's terribly important to remember the role of the counsellor. We are busy as doctors. We can be empathetic to an extent, but we do have to get on with the next patient. It's terribly important to have a carer, someone else who can hear the information, and someone who's got a bit more time than the person doing the examination, who then reiterates what's been said and gives the patient more time, listens to their concerns, as Dr. Correa suggests, feeds them on to get more help for their immediate concerns, because they're often not our immediate concerns. And that can be done in the field, and it can be done at base. So I think a patient counsellor is terribly important to help to put the emphasis more on the patient and what the patient is going through, rather than what we focus on, which is the treatment.
Thank you very much. Dr. Kishangi, what about in training programs or in ophthalmological societies? Because we have several societies, we also have several training programs in the country. How can we be more patient-centered from now on?
Thank you. I first want to say that we are talking about people-centered because we would want to take care of people's health even before they become patients. And so we are talking about health promotion to ensure that those people remain healthy. They don't have to get into a situation of being patients. So we talk about health promotion and health, prevention of diseases. And then treatment, you treat a person or a patient in the context of the work a person does, for example, is a school-going child, or somebody needs to read at night and so forth. So we are talking about people-centered eye care. Now, when we get to training, I think these concepts need to be entrenched into the training, that in addressing a disease entity, for example, you should have the different components of treatment or intervention: health promotion, prevention, and curative. And if you are in a situation where you are irreversibly blind, then there is provision for rehabilitation so that you can be able to go about your daily living. So that's what we are talking in terms when we mean patient or people-centered care. So this concept should be entrenched in a training program, that you don't talk of addressing glaucoma, just prescribing Timorol or TET, but it is looking beyond, ensure that aspects of prevention, screening for the high-risk group who are, within that, are taken into consideration. Thank you.
Thank you very much. Thinking about those two patients, they both talked about, barriers or issues that they face. And we have been talking about universal health coverage, not leaving anyone behind. How do we ensure that our services, whether cataract services, glaucoma services, diabetic retinopathy services, how do we ensure we're not leaving anybody behind, particularly the most at risk and the most disadvantaged? That is like the very poor, the uninsured, the elderly, the visually impaired. How do we make sure we are not leaving them behind? Do we have a mechanism of capturing data that we can use to find out who we are leaving behind? Do we examine that data? So some thoughts on that. Maybe Dr. Roberts first, then Dr. Coril, and then Dr. Gishangi.
Okay, well, I think that's very important, and that's been one of the biggest challenges from the beginning in ophthalmology, particularly in Kenya, where we don't yet have everybody registered and everybody easily reachable. And I think that the only answer really is to go to the patient if the patient doesn't come to you or cannot come to you. So some form of grassroots linkage or grassroots program with people who can reach the patient, whether they're going to be part of your eye center and salaried workers, or whether you're going to work with community health workers and the government people on the ground and other people who will see these marginalized people and enable access. So I think there is still very much a role for field services and a good grassroots community service. And that's not just for identification and treatment, but very much for follow-up. If you look particularly at the role of low vision and education, you must have a solid, well-supported grassroots program for these marginalized people. Otherwise, you simply won't reach them.
Thank you, Dr. Correa.
Yes, I totally agree. I think the vulnerable group are the ones who tend to have a lot of, they have more of these eye problems. And I think one of the things that came out in the World Vision report is just improving the primary eye care and, this training of community health workers. And I think something that is coupled with that also is healthcare financing. These are the same community which will have challenges in terms of getting a fund, being able to afford the treatment if once they have been able to access it. So that also need to be addressed. And I think national NHIF, National Health Insurance Fund, is one of the things I would say would be really key for this vulnerable group. Thank you.
Thank you, Dr. Gishangi.
I agree with what the others have said. And in addition to that, I may want to say that we will need a lot of partnership with different stakeholders in all this. One thing or one aspect we need to embrace strongly is generation of evidence. We need to establish exactly who is able to access services, who is not able to access, and also to a great extent establish why. And then from the national government point of view, we need to use that for accurate planning and be able to focus, probably where we need to add more resources, and those who may not be able to finance their health, the national government should be able to take up that responsibility.
Thank you very much, Dr. Kishangi. In this conference, we have also talked about 2 documents, one, the National Glaucoma Guidelines, and also the National Strategic Plan 2020 to 2025. I know in previous times we've had other documents. So let me begin by asking Dr. Robert, how do you use these documents at the facility level? How useful are they and what do you use them for?
Well, they're put away in a file for most of the time and put away on the shelf, and everybody loses them. But I think that we don't have to have that attitude. I think we've now got mobile phones. We used to ban mobile phones with clinicians, but actually that's now stopped because you've got such access to so much data. And this is a really valuable document. It's a guideline, as it was emphasized very clearly by Dr. Kiagi. It's up to the clinician, but this is there to help you as a guideline. So easy access. And this is available online, the glaucoma guidelines. I'm sure it's available on the OSK website, etc. And they need to be revised at regular intervals and interaction around the guidelines used. So they need to be at our fingertips and they need to be part of what is taught so that the ophthalmic students, not just those specializing in glaucoma, are familiar with these guidelines and others.
Thank you very much. Dr. Correia, what are your thoughts about how we can fund some of the recommendations like case finding or early detection or treatment? How can we fund, for example, those activities for glaucoma?
That's a tough question, but I think this is where it involves a lot of partnership. I think a lot of NGOs, I think, are available and willing to partner. And I think it's up to us. Dr. Kishangi has clearly pointed out that, we have to look at the full spectrum of the patient treatment. And it's true that it's easier to treat something when you catch it early or to prevent it rather than to treat it much later on. So it makes a lot of financial sense to invest in screening and all these things for, primary healthcare, getting it early, training patients, putting out educational material so that we prevent this much later on, trying to sort it out. It's more expensive, so partnership and screening. I think that would be my recommendation.
Okay, thank you very much. And Dr. Kishangi, we need referral for this condition. The referral mechanism should be working so that these patients get referred appropriately. How can we strengthen our referral mechanisms? Maybe between secondary care and tertiary care, or even between primary, secondary, and tertiary levels?
Okay, thank you very much. Before I get to that, I want to say that for example, it's the responsibility of the national government to develop these protocols and policies and so forth. We do not just develop, but we also from there develop tools for implementation. For example, what is it that a primary healthcare worker would need to do in the context of glaucoma guidelines? And then, for example, as Dr. Kege was saying, we can develop some posters and flowcharts which can be posted within primary healthcare facility or different levels of care. And that way, that's how we implement guidelines. Again, we'll also develop some training mechanism or capacity building of the eye care workers in the field in the context of the guidelines. And with what each one has, the resources each one has, it will be possible to do something contributing towards care for people with glaucoma. Talking to referral, again, the National Strategic Plan and also the glaucoma guidelines indicates what you should do when you find what. The referral pathways and systems, within the levels of care. Thank you.
Thank you very much, Dr. Kishangi. Now, Professor Karimuri talked to us about being a clinician, a researcher, and an educator. We know there are some barriers that that may be faced by clinicians in doing research? What sort of barriers maybe have been faced by clinicians? Maybe Dr. Coril, maybe in a few seconds.
Great question. The biggest barrier, I think, is, as a clinician, we see a lot of patients. I come from a very busy hospital. I see a lot of patients. And quite honestly, I have a very good research questions that come out in my mind. I see patterns, and I have questions in my head. But to sit down and to research on it, I hardly have the time. So one is the time. Two, this happens over time, and it's been very many years since I finished, graduated, and my research understanding and modalities has gone down. So I'm not confident enough to create a methodology and actually try and answer the research question I have. So as a clinician, I have very good research questions, but how to go about it is a challenge. So, and the two barriers is just the time and the skills that I lack. Thank you.
I'm sure those are also the barriers many of us face, and let's continue discussing them and seeing solutions so that we function as clinicians, researchers, and educators. I will now give Dr. Judy Derrito some time to ask some more questions. Thank you.
Very nice discussion. Thank you also to the panelists for that fantastic discussion. I'd like to address Dr. Lila's question to Dr. Bishangi. Dr. Lila Raj Puri on the Hoover app had asked, is the integration that is being advocated in the World Report on Vision feasible, considering the constraints in human resource and primary level healthcare? So Dr. Bishangi, please.
Thank you. Again, integration is possible to a large extent, and we talk about that because that's the way to go. We need to work with community health workers, engage the communities to be able to take up health as their responsibility. That is what we can. And earlier on, I had mentioned that intervention at that primary level usually cost little, but they have higher return. We may, or rather we are really short of workforce, health workforce, all different types of workforce, not just eye care workforce, but the best way of using the limited workforce that we have is to ensure that we address issues at primary level. Remember, that is when diseases are setting in, and treatment or intervention will be cheap and will not need to go to higher levels where the cost of treatment will be higher. So in that way, with the limited workforce we have to embrace primary healthcare. We have to embrace integrated approaches. Thank you.
Thank you, Dr. Bishangi. Dr. Mushai Kashago has some questions for the other discussants.
Thank you very much, Dr. Nyawera, for taking us through that session. We have a few questions from attendees. The first one is to Dr. Kiage, and the question was, what are the indicators for monitoring glaucoma programs at facility or county level? And the response Dr. Kiage has given to this is that the indicators are not yet fully well developed. And he suggests that really what you can do is track the outcome of interventions, as has been done for cataract surgery, because for cataract surgery, they are pretty well defined in terms of what kind of visual outcome you're expecting on day one, at a month, and even up to 3 months or a year after treatment. So that is what he recommends. And some of this, of course, will include the intraocular pressure as well as the disc assessment findings. Another question I am seeing addressed to Dr. Kiage is on the guidelines. Are they available online? And I'm sure that's a question that everyone is asking, because then that would give us, a way forward. And that was from Dr. Puri. And the guidelines will be available online because, we've gone virtual, so will the guidelines. So they will soon be uploaded on the OSK website as one of the resources. So keep your eyes peeled on osk.or.ke, and you'll get the guidelines. They shall be uploaded there very soon. So those were the questions addressed to Dr. Kiage. We have some questions to Professor Karimorio. And first question was, should we wait for final research results, or can we encourage people to present earlier? And this has been seen where people publish certain segments of their data before full publication, or even just their methodologies. So Professor responds that in the initial stages, you can actually publish part of your literature search and also the methods that you're intending to use, so that then as you conduct your research and start getting in your results, people are already fueled and want to look at your research methodology, kind of in preparation for the final results you're going to put out. And he suggests that that can be done in the earliest stages, because then you have to plan. When finally you have your results, then you can give that out. Now, a question here has been put to Dr. Karimorio, but I think I can address it to Dr. Gishangi, since Dr. Karimorio is not on the panel. And the question is, what support is the government of Kenya or the University of Nairobi giving in support of private practitioners who are interested in doing research? And I think Dr. Korir had already alluded to that, so I think Dr. Gishangi can fill us in on that.
Thank you. That question. First, I want to say that one barrier I see in research is probably the mindset from people with questions or research questions, and also the perception that you know, it's such a big issue. Now, one would start simple. Try answer question even with the clinical patients that you have. For example, what are the outcomes of, you know, treatment of patients on this and so forth, and then from there you build on. So I would want us to not see research as, you know, a big monster, but we start simple, even with the everyday data that we get from our clinical practice. Now, with respect to private sector and research, I think as ICARE moving forward, and it has been documented in the strategy, and I also put it across in our presentation, that we have come to realize that the private sector also contributes significantly to healthcare service delivery, about 50% equal. And so we are enjoining the private sector in our planning, and we in the same way would wish to include them in such activities. Thank you.
Okay, we still have 2 minutes, and I think I could address this to Dr. Gishangi can address this in terms of costs and HR. How are these being planned to address the magnitude of glaucoma? And I think from the government strategic point of view, cost and HR and the magnitude of glaucoma, what are you doing to address that?
The magnitude of glaucoma is big, and what we feel we need to do is probably opportunistic screening is what is recommended. Those patients who are already presenting themselves to hospital, we should, those who are at high risk, we should screen them for, you know, the risk factors, and then address them. And also for the patients who are presenting with glaucoma, you know, there is the familial aspect of it, and so we should encourage that, you know, you have the other siblings or relatives be assessed. Now, the cost of treatment, I know, is also high, but again, we are into partnerships with different stakeholders, including NHIF, to address the issues of meeting the cost of treatment for glaucoma, and also the other aspect of looking at who is it that should treat, glaucoma, or how should we train workforce to be able to address issues of generally eye health. The costs are huge, and as a ministry, we are planning or having a strategic plan for workforce development. Remember, I talked about developing other centers for training eye health workforce. Now, the government will put in the resources that would be needed significantly. Again, we are not always able to get everything ready and in time, but we are moving in that direction of training more and more workforce. Thank you.
Okay, thank you, Dr. Gishangi and panelists for taking up those questions. Very informative. I think I'll hand it back to Dr. Korir to give us final remarks.
Thank you very much, Dr. Muchai. This has been a really wonderful session to just tie up everything that we've been learning. From the morning, we saw the patients, and the whole theme has been, being patient-centered, and the fact that there are many documents that we've discussed today: glaucoma guidelines, the Kenya National Strategy for Eye Care, and one patient said, "Stop talking and do something." And I think that's really the message for today. We've talked about so many things. They need to get done. Those guidelines don't need to sit on the shelves. Let's turn them into SOPs, as Professor Kiage has said. And then it will make sense, and it will translate to better patient care. Thank you very much, Muchai. Back to you, Muchai, Dr. Nyawira.
Thank you very much for attending our panel discussion today. This is our last session for today for the conference, but tomorrow again we still have a conference at the same time, early morning. I hope you are learning. Do send us questions on the chat. We will continue to answer them even the rest of the day, the rest of tomorrow. Thank you very much and have a good day. Thank you.